it's my great pleasure to introduce our third speaker today, and Dr. Candice Monson. She is a professor in clinical psychology at Ryerson University, and she is the president-elect of the International Society of Traumatic Stress Studies. And she published over 150 scientific articles and 8 books in the area of traumatic stress recovery. She also co-authored books, and you will learn about those books in her talk. So the topic of her talk today is post-traumatic stress related to COVID-19 and how we facilitate recovery. Please join me to welcome Dr. Monson.
Sorry about that. I realized that I needed to unmute. Thank you so much, Leisha, for having me this evening to talk about traumatic stress and recovery, and especially how it intersects with COVID. So I'm going to just take a second to share my slides. All right, so this evening I thought I would spend a little bit of time talking about what is trauma. You'll notice I have that in lower caps, so small t, trauma, sort of more colloquially known, and also capital T, trauma, as we think about it as traumatic stress that might cause post-traumatic stress disorder. Some of the common reactions and the recovery trajectories after people are exposed. And then specifically to talk about PTSD in the context of COVID-19, and a little bit about what we know about the treatments that work. So the evidence-based treatments for PTSD. So just to start, to talk a little bit about what is trauma. So there's different ways to think about trauma. So you might think about it as extremely stressful life experiences, also stressful experiences that are passed down and shared amongst groups and families. So we might talk about this in terms of intergenerational and historical experiences that people may have experienced. There's also the term intersectionality, or ways in which people might have traumatic experiences that intersect with other types of experiences related to race or ethnicity or gender or sexual orientation that may make those experiences especially stressful. There are lots of kinds of things that we might think about as colloquially trauma or traumatic. So if someone's spouse has an infidelity, that is traumatic for the person who's the non-offending spouse. Or if we can't spend time seeing our grandchildren or touching those people that we love, we might think about those things as colloquially traumatic. In our diagnostic system, though, we tend to think about certain events as traumatic. And those I'm going to refer to as capital T, in that they have a certain set of qualities to it, at least according to a committee who makes these diagnoses, and is part of the diagnostic criteria for the DSM, the Diagnostic and Statistical Manual of Mental Disorders. So according to the DSM-5, what makes a trauma what we call a criterion A event is that it includes exposure to threatened death, actual or threatened serious injury, or actual or threatened sexual violation. And that's by either directly experiencing it, witnessing it in person, or learning about it in terms of a close other. So in fact, these kinds of experiences are more reliably shown to cause the kinds of symptoms that we're going to talk about here in a minute that are called post-traumatic stress disorder. And there's also a set of experiences with the most recent diagnostic criteria where we know there are some people who are repeatedly exposed to extreme situations like handling body parts or first responders who are, coming on to emergencies or scenes. And by virtue of that repeated exposure may also be at risk for post-traumatic stress disorder. Now, one thing to know that may or may not surprise you is that actually in North America, and these are statistics specific to Canada, trauma a la DSM-5 is actually quite endemic. So it's very, very common for all of us. In fact, you'd be the exception if you weren't exposed to one of these events, at least one of these events in your lifetime, with women being slightly less likely to be exposed than men. And in fact, most of us are exposed to over 2 different types of these exposures. So whether that's childhood abuse, a motor vehicle accident, serving in combat, whatever the exposure is, most of us are exposed to one of these very stressful experiences. Now, the truth is, though, that over 75% of us are not walking around with PTSD. And what this chart shows you is, let me start with the take-home message, and then I'll walk you through it, is that most all of us, with time, will recover. That the typical trajectory is toward recovery. So in this graph, it's actually 3 different studies. And on the y-axis is the percent of people in the sample who would meet criteria for PTSD, the x-axis being over time. And so you can see there are some studies that have evaluated people as soon as 1 week post-rape. So a completed rape, there were 2 different studies that did that on a weekly basis. And what you'll see is at 1 week post-rape, about 94%, in this case they were all women, would meet criteria for PTSD, but for the month criteria, meaning it has to be after a month in order to be diagnosed with PTSD. And then over time, what you see is that by about 3 months, 50% of the samples are diagnosed with PTSD, about 50% of them not. And that's in the case of completed rape, which is one of the types of traumatic experiences that are most likely to lead to PTSD, along with combat, actually. But the other thing I want to point out is in a study that we just completed actually in Canada, looking at a very heterogeneous group of traumatized individuals that we followed over a year, you can see that people continue to improve even up to 15 months post-trauma. So again, our sample at 6 months post-trauma, about 50% of them would meet diagnostic criteria, and then it goes down to about 17% at 15 months post-trauma. So a really important point, I think, compared with other mental health conditions, PTSD is really a disorder of impeded recovery, meaning like something gets in the way of a natural recovery trajectory. So unlike other mental health conditions like depression or schizophrenia or bipolar disorder, where there might be like early signs or what we call a prodromal phase, in PTSD, when people are removed from the threat, they tend to have the most symptoms, and over time, those symptoms abate. And so in this way, you might think about PTSD as a disorder in which something got in the way of that recovery. And that's what I really want to talk to you about today, is ways that you can facilitate recovery, knowing that lots of people will be exposed. So in Canadian lifetimes, about 9% of individuals will receive a diagnosis overall, but you can see that women are over twice as likely in Canada to be diagnosed with the disorder compared with men. And at any one point in time, about 2% of the population is diagnosed with the disorder. So in fact, it is one of the most common and also one of the most debilitating disorders in Canada, in North America. Now, you may also be interested to know, transitioning here to talk a little bit about PTSD and epidemics and pandemics, that PTSD is actually one of the most common diagnoses that result from these kinds of experiences. So, for instance, in a systematic review of infectious disease outbreaks, so that included the 2003 SARS outbreak, the 2009 H1N1 outbreak, and occupational exposure to HIV, the average prevalence among healthcare professionals was about 21% for those people who were exposed, ranging from 10 to 33%. And as you might imagine, the closer people are to caring for people who are suspected to be infected or who are infected are more likely to have the diagnosis. And in fact, 40% of those individuals who had persistently high symptoms or met criteria had those symptoms 3 years after exposure. So it's not a short-term presentation of the problems, but actually it seems like these problems are lasting even beyond their caring for individuals who might be infected with these various infectious disease. And there's also research showing that PTSD was the most prevalent long-term psychiatric condition among SARS survivors. So the cumulative proportion, meaning the highest number at any one point of those who were diagnosed with PTSD was almost approaching 50%. And 30 months post-SARS, 25% continued to meet PTSD criteria. And some of the recent data coming out of Wuhan suggest about 7% of those that were there during the COVID-19 breakout had clinically significant PTSD symptoms, with women more likely to have clinical levels of the symptoms, so more likely to have the disorder and to have more of the symptoms than men. So I raise this in that I think this is a condition, or at least symptoms, that people are likely to present with by virtue of being a healthcare worker that, for instance, is exposed to someone who is dying and they feel like they are dying alone or maybe dying in a very difficult way. There's already, you probably have seen in the public media reports of healthcare providers, at least one physician in the news who had suicided related, to her exposure to these types of events. And so there's also been a lot of talk of this construct of moral injury or moral distress, meaning individuals who are put in these morally compromising positions as healthcare providers, or perhaps as people who aren't trained as healthcare providers, like the Canadian military, who are going into long-term healthcare facilities to try to help people who have been impacted by COVID and are not properly trained in terms of administering the care and also being with people in these emotionally difficult circumstances. So I do think this is something we're going to see more of, and that we all can potentially play a role in from a public health perspective in trying to facilitate this recovery. So speaking of that, how do we understand? Remember, I said a lot of people have the symptoms and that a lot of people get better. So how do we understand how people get better? So we've tended to take a biopsychosocial approach to trauma recovery, meaning that, yes, there are genetic biological predispositions like the size of your hippocampi, do you have polymorphisms on your serotonin gene transporters, but also other levels in the social ecology that can impact on people's trajectory. So things like social support and how close people feel to other people in their community. Also minority stress, people's economic situations, that all of those things have a role in how people recover post-trauma. And just to kind of help you understand how you might and how we facilitate this recovery, it's very helpful to understand the symptoms of the disorder. So there are really 3 different major groups of symptoms. And the first group, after an event happens that people will have, whether they end up with the disorder or not, is a lot of intrusive images and sensations. So, and you can think yourself, if you've encountered something traumatic, either, capital T or small t, you probably are thinking about it a lot. It may pop into your mind. You might have nightmares about it. These are ways that your body is essentially, your body and mind is trying to digest what happened by bringing it back up in order to figure out what to do with it. Now, when that happens, when we have those sensory perceptual experiences, we also will have thoughts about it and emotions about it. So people who are recovering in the wake of trauma often, for example, are trying to make sense of why did it happen. So did I do something wrong? Was I in the wrong place at the wrong time? Did I follow the procedure? Did I send the wrong message? Could I have done more? Should I have been able to get PPE someplace else in order to intervene and be more effective? They have a lot of thoughts that are going on as they're doing the post-mortem, right? So they're retrospecting and trying to put the experience back in some sort of place in their memory. Now, people can also develop, based on these negative experiences, quite negative beliefs about themselves, about the future, about others. They might, for example, develop a certain set of beliefs about a class of people. So people of a certain ethnic, racial background, or maybe of a certain gender. They may have these overgeneralized beliefs that develop that can be very problematic in terms of their own mood and anxiety. And that relates to the kinds of emotions that people will experience. So people who are struggling in that recovery will have very negative emotions. They will also lack positive emotions and feel detached from other people. Now, the third classic set of symptoms are alterations in people's arousal, their physiological arousal, and their reactivity. And you'll see this in, for example, people's startle response. They'll be really easily startled, or they'll have lots of difficulty sleeping, or they'll be irritable, or they'll have poor attention and concentration. All the markers of our psychophysiological system running amok, right? So running too high level and revving on the person. And they may be more likely to be reactive in the way of being aggressive or impulsive. And when people have PTSD, these symptoms are interacting with each other. So the intrusions are causing people's nervous systems to be more reactive and more aroused. They're thinking about it because they have those intrusions, and they're having feelings, which is then influencing how likely they are to have the intrusions and reactivity. So all of those symptoms are rebounding off of each other. And when people are having that, none of us want to walk around chronically feeling negative and also having a lot of arousal. Like, it's very normal for organisms to want to escape and avoid. And so what you will see people developing is a pattern where they will begin to avoid things that remind them of any of those prior experiences that can then trigger their emotions or their memories of it. So they might, for example, avoid hospitals. They might avoid doctors. They might avoid any place that they think there could be germs. They might avoid any movies about death and dying. They might, if in the case of a motor vehicle accident, they might not drive. Or if they have been assaulted and it was at dark, maybe they don't go out after dark. So depending on the experience, then they might start constraining their life to escape and avoid. And this box over here is just a list of all the kinds of different ways that people can avoid internal reminders and also external reminders. And those can take on more or less convoluted ways of avoiding over time. And I always say there are as many people who avoid as there are people who have trouble recovering after a trauma. It's a very typical, understandable response, but it's one of the most important things to stop in terms of treatment. So I'm going to go back to that slide that I just flipped over to say all of the most effective treatments for PTSD. And my number one suggestion, if you or a loved one is traumatized, is to be extremely compassionate with the idea of wanting to avoid and to do exactly the opposite. Because it is that avoidance that maintains that set of symptoms that are colliding and bouncing off of each other. And all of the treatments that work the best aim to stop that, to motivate the person, whether it's an early intervention or later once, PTSD has taken hold, that's really designed to motivate the person to understand that, by avoiding, you are preventing your mind and body from learning something new about your circumstances, because you're depriving yourself of the opportunity to put yourself in places, situations with people that are reminiscent of whatever the traumatic event that you have experienced reminds you of. So all of them do that. And honestly, it's probably the most important thing that one can do in the wake of trauma, either to support someone else or for yourself, to help facilitate the recovery. Now, just to go back for a second, this is a meta-analysis. It's a little bit old now. It's about 7 years old, but I like this meta-analysis because it includes both talk therapies and somatic therapies in one study so that we can compare apples and apples in terms of the effectiveness or efficacy of these treatments. So just to orient you, the green bars are the talk therapies and the psychosocial therapies, that's probably a better label for it. And the blue therapies are the somatic therapies, most of them the drug therapies. If you don't deal in effect sizes every day, it's okay. All you need to know is bigger is better. And it's kind of like a standard deviation's worth of difference or improvement. And you don't want a negative effect. So hopefully one of the first things that pops out for you on this slide is that the talk therapies, the psychosocial treatments, are the clear winners when it comes to PTSD. In fact, most people think about in psychiatry and the drug therapies, how we might use drugs to potentiate talk therapy. It's that much further ahead in terms of the effects. You'll notice that, just to point out a couple of things, the top therapies and the talk therapies are cognitive. So Dr. Antony talked about how you might change your mind. So those are the treatments that are really looking at people's cognitions or their thoughts. And then the exposure therapies are those ones that he mentioned, and we're going to talk more about, of having people face what it is they fear so that they don't fear it. And so the top three actually four, are really under that broader rubric of cognitive behavioral therapies, with the top three being what we call trauma-focused treatment, which means we're focused on the traumas that happened, and by going backward to look at them, face them, we actually help people move forward and go beyond PTSD. There are some treatments that are more symptom management, like skills-based and stress inoculation training, which have good effects, maybe not quite as big. You may also have heard of EMDR, which is eye movement desensitization and reprocessing therapy. There's a lot of controversy with this particular treatment because it includes some type of repetition in eye movements or in tapping. And there's lots of questions about whether or not you need to move people's eyes or tap in order to get the effects, and rather whether EMDR is another form of cognitive behavioral therapy. I might also just point out there has been some promising acupuncture trials. However, as you might imagine, it's a little bit challenging to have a good control condition for acupuncture, especially now as people are more savvy about what is involved in acupuncture. And so there's probably some more work needs to be done in terms of the methodology and really testing whether or not acupuncture has promise in the case of PTSD. But again, the medications have very modest effects, and in fact, some of the medications are contraindicated. For example, the benzodiazepines, because of their addiction potential and their very modest effect on PTSD symptoms, are contraindicated in the case of PTSD. So again, a reminder, all these treatments that work are designed to try to prevent avoidance. And I wanted to just give you a little bit of a flavor of what each of them are focused on. So if you had a fear of spiders, or if you had a fear of flying, or if you had a fear of flights, one of the best treatments, and Dr. Antony mentioned this, are the exposure treatments. And in the case of PTSD, what we are focused here on now is the trauma memory and the idea of taking people systematically back to those memories, reminding them they are memories. The memories cannot hurt you. And if we go back and face them systematically, then you will not be afraid of them, either in your imagination or also in your environment, in places, people, situations that are reminiscent of it. And so the two most prominent types of exposures are the imaginal exposures, which again are in the mind, and the in vivo exposures, which are in real life. And the treatment package that is most researched and kind of the best training programs offered, I would say, are Edna Foa's prolonged exposure treatment for PTSD. Now, if you look at this picture, I'm sure some of you will see a man with a big nose playing a saxophone. And some of you might see, now that I add in the red line, the woman's face. And this is just as a reminder that what I see in one thing, another person might see as something else. And that perception is everything. And this is kind of the basis of cognitive therapies and looking at how people perceive things and trying to work with the client to identify those problematic ways of thinking, either as they look back about the trauma or as they look forward and take what they learned from the trauma and overgeneralize it into the future. So, for instance, if you're a healthcare worker and someone dies of COVID, and part of the way you make sense of it is that we didn't have the proper equipment, leadership or administration didn't properly outfit us or prepare us. And then you might develop a set of beliefs about no one will protect other people. I won't be able to protect other people. So it can influence the way kind of we think about ourselves and other people. There are different kinds of cognitive therapy. Some of it is trauma focused, kind of like the example I just gave of, how people make sense of what happened in terms of the trauma. Others are not trauma focused. It's more about kind of the here and now and how they make sense of all kinds of other everyday events. These treatments may or may not include behavioral assignments, so written trauma accounts, behavioral experiments, and perhaps one of the most well-known of these cognitive therapies is cognitive processing therapy for PTSD, and I've included the book cover here. I'm one of the authors of this therapy. It is one of the frontline recommended treatments for PTSD, along with prolonged exposure that I mentioned before, as having some of the best data for improving PTSD. CPT specifically is designed to be 12 sessions long. It is under that broader rubric of cognitive behavioral therapy. It is much more focused on how people think, and it may or may not include having people write a trauma account, and it is a treatment that can be delivered in groups or individually. And just very briefly, because I know we're running out of time, another treatment that I've been involved in is cognitive behavioral conjoint therapy for PTSD, which is a treatment for PTSD that includes loved ones in the treatment. It is focused on the trauma that one or both people have experienced, but it does not require the person who has been traumatized to go back and remember and share the specifics of those trauma memories in a lot of detail, because it's based on a cognitive model, not on that exposure model. One of the important things I think as a community and as just people in society to remember is that social support is incredibly important to people's recovery. So part of us developing this treatment was really trying to recognize people's relationships matter. So the degree to which we are emotionally supportive or practically supportive when people are unwell or struggling, this is very important ingredient that we can offer to those who may be in need. And just a little bit about the treatment. It's 15 sessions long. The sessions are about 75 minutes long, and we have applied it to a range of dyads. So mostly it's been with couples, but it also includes some sister-sisters, some mother-sons, and also some best friends as co-participants in the treatment. And we also, related to that, we recently launched Couple Hopes, which is an online version of the couple therapy for PTSD. So there's a platform with web stream videos, interactive exercises, and a little bit of coaching by a paraprofessional to help people engage with the material and actually do the practice assignments and benefit from the skills that are being taught through the platform as another way of trying to reach as many people as possible who are geographically dispersed and also maybe more reticent to seek therapy proper, but are looking for another strategy of accessing care within their community. So I would be delighted for anyone to reach out to me if you have any questions or concerns or potentially want more information about PTSD or trauma recovery more generally, and really appreciate the opportunity to speak within your community and to help as many people as possible, as we're all really struggling with the stressor of COVID and all that it's bringing to us. Thank you.
Thank you very much, Candice. And let me share my screen with my 5 minutes Mandarin summary. I know we are running out of time, but I still want to, because the message is very important, and I want to keep it short. Okay. 这个 Candice 她讲的是疫情创伤后压力的缓解，就是关于这个疫情创伤后压力综合症这样的它的缓解和恢复。那么在美国，它有一个对于心理健康疾病的诊断量表诊断书，就是 manual， 我们可以 follow， 根据它的这个诊断标准来判断呢我们有没有心理问题。那这个就是 DSM-5。在它里边呢有一些标准来判断呢是不是有这个 trauma， 就是创伤，心理创伤。一般来说呢，这个创伤呢就是比如说有很严重的这种心理上的一些经历，比如说受到死亡的威胁，或者是有严重的真正经历过的，或者是被威胁严重的伤害，人身伤害或者性暴力。那这些呢都可能会造成创伤。那你的经历结果也可能是你直接亲身的经历，也可能你看到别人经历这样的事情，或者是呢听到你周围亲近的人经历这些事情，你就会在头脑里边一遍一遍的重新的演这个细节。那这个时候呢，你的心里头是有创伤的。那创伤恢复呢，它有受到这些生物、心理、社会因素的影响。那生物因素呢，就是说有的时候呢，我们就是基因决定的有一些这样的因素，还有一些呢，就是我们心理上的认知呀、情绪呀，就是我们对事情的一个诠释呀。就像刚才这个讲座里边讲的，就是同样一个事情，大家从不同的角度去理解，那就会得出不同的解释，同时呢，就会引起不同的情绪反应。trauma 呢，一般来说呢是会有很多的负性的情绪，还有呢就感觉跟别人就失去了感情的连接。那在我们行为上呢也会有一些的表现，比如说我们会有一些这个逃避性的行为，易怒呀、攻击呀、暴躁、自我毁灭什么这些呢都是跟 trauma 有关系的一些表现。那在PTSD 呢，它就是这个应激压力。关于压力后的这个创伤后的压力综合症呢，这些呢，它有一些治疗的方法。那 Dr. Monson 呢，他提到过的，就有效的一些方法，比如说暴露疗法，就是呢，让你你觉得特别害怕，就可能会直接呢就给你让你呈现在这种状态下。那在心理学里边，他们做过实验，比如说小老鼠，它给它电击，那电击呢，它怎么也逃不脱，它慢慢的就在电击，它慢慢的就跟这个电击就学会生存，那就慢慢的它这个焦虑呢，慢慢就降低了，这就是一个焦虑的习惯化。那还有呢，你可能真正的暴露呢，可能就是说这有危险呢，你可以想象的暴露在这样一个危险的或者让你痛苦的那个，重新回到那个你受创伤的情景之中，然后呢学习coping。还有一些就是最有效的方法，根据他这个最近的一个 meta analysis， 就是把好多的研究的综合起来一起来比较呢，他认为这个认知疗法，就是我们所谓的社会认知方面的这种疗法呢，它的效果远远高于就是管症状的这些吃药这样的疗法。所以呢，就是说心理上的这个疗法呢，还是在治疗 PTSD 上还 还是特别有效呢？他提出来这个认知疗法也是他写了2本书，一个是认知加工疗法，还有一个是认知行为综合疗法。那这些呢都是特别有效的，对这个 PTSD 有帮助的。那他有一点呢，我觉得特别清楚，就是这个事情越回避越不行，就是逃避解决不了问题，越逃避呢，可能就是情况就越恶化。所以呢，就是需要我们重温这样的一个情境，而且呢，要有一个接纳的心态来认真去面对。才就像我们Dr. Antony 讲到的这个 fear 的时候呢，也是 exposure 呢，其实是一种很好的一个疗法，就是你必须得面对它，而不是逃避。好的，那就是我们刚才看到 chat 里头有人问哈，这个someone in the chat room asked about where to find the books. So I show this slide and you can feel free to take a picture, and those are all the books included in the slides of the speakers. And if you want to buy the books, and you can take a picture and you can search it up from internet, and you can find the book you like. Okay, so I want to thank all the speakers, and let me see, and we do have some questions, and I'm not sure whether the speakers will have time to stay for a little longer to address the questions. Okay, let me stop my screen. And Marty, Candice, and Alex, is it okay for you to stay for a little longer to address some questions we have? And we got some questions from registration, and we also have some questions from a chat room. And maybe we can start with questions from a chat room. And anyone, and you feel like this is right to your topic, and you can feel free to just anyone can jump in and answer the questions. So the first question is like, I have oh, okay, so no, this is not the first one. The first one is how to manage stress with 2 young kids at home and at the same time, and I have to work from home, and I don't want the kids to have too much screen time. And what can we do what can a working mom to do to survive? So I think this is related to stress and related to coping. And who, Marty or Alex, whoever want to take this question, or it can start.
I guess I'll jump in. None of the 3 of us have 2 young kids at home, so don't have a lot of experience with dealing with that in the context of the pandemic. I think my approach would be to take a bit of a problem-solving approach to this, to try to figure out exactly what the parameters of the problem are. So for example, I'd want to know a little bit more about the children. What are some of the other activities that they're engaged in? Are they doing any camps? Are they going back to school in the fall? Is school going to be online or not online? So I'd want to sort of understand the parameters. I'd want to know if there are other supports around. Is there a partner around? How old are the children? Are there other relatives around who might be able to help out? So if we can kind of just figure out what the situation is, and then brainstorm possible solutions, recognizing that right now during the pandemic there are going to be no perfect solutions. So whatever you end up doing, it's going to be a compromise. It's not going to be great, but it might be the best you can do, and giving yourself permission to to make do with a situation that just isn't very good right now. So it might, I'm looking at screen time, for example. Whatever sort of guidelines you might normally have for screen time might need to be compromised a little bit during the pandemic or during this situation, and trying to figure out how much you can get away with compromising. So that's sort of how I might think about that.
Okay, Marty, and I have a follow-up questions for you related. And there is a mom and who have how can we with dealing with the depressed kids, and I think that's like a not caregiver to the loved ones and who suffer from depression or anxiety. And do you have any comments or advice for the mom?
Sorry, can you repeat that? So the
mom and has kids and who is depressed and want to have some advice about how to provide caregiving to depressed kids.
Yeah, so it's hard to give clinical advice about a specific case without knowing more about the situation, without really doing a full assessment with the child, because depression, even though the symptoms are similar across people, the types of factors that contribute to depression for any one individual may be very different than what they are for another person. So in one person, it may be their relationships that are really contributing to the depression. In another person, it might be the type of work they're doing. It might be again, the way they think about things, the level of activity. Like there's so many different things that can contribute to it. So I think in terms of how to deal with it, I'd also want to, would wonder how old the child is, because that could affect the way that it's handled. I think there's a few options. So, one is learning a little bit more about depression to see what kinds of factors might be relevant for this specific child. There's some good self-help books out there for parents, for example. Seeking help from a mental health professional, a physician, maybe to get a referral, a psychologist, a social worker, somebody who has some experience with treating depression, particularly in children or adolescents, depending on how old this child is, and maybe getting an assessment and getting some treatment recommendations. That would probably be sort of what I might suggest, not knowing more about the specific case. And then I guess keeping some of these strategies in mind as well. So if the child is sort of withdrawing socially, for example, so finding ways to help the child to engage more socially with friends, if that's an issue for this child. So trying to take into account the sorts of things that we've talked about today to see if any of them might be relevant for this particular child.
Mm-hmm. Thank you, Marty. And I think borrowing Alex's point, and maybe like self-care is very important for the mom as well. And whatever you are caring, and kids with depression or anxiety, and so at the same time, and we need to self-care, and that's before we care others, right? So Alex, and do you want to add? I see that you do you want to add some comments to the first and the second questions?
I guess with respect to the first question, not knowing what to do with your children during this time, and you want to ensure that they stay on some sort of schedule, and you don't want them to engage, perhaps again, not having too much screen time. I think that again, it's sort of letting things slide a little bit and understanding that this is kind of a special time. And so just as an example, I had a conversation with an individual, a mother with 2 boys, and homeschooling, and again just having a lot of discomfort and tension around that, and that whole relationship where the mom had to become the teacher really did create tension. And so telling them, giving them a schedule and saying, this is what you have to do every day, and it created a lot of tension. So at one point she realized that, it was just about, okay, let's just take next week off. And you know what? Normally we wouldn't do this, but this is a special time, and I have to take care of myself. So it's about sort of really being compassionate towards yourself, and it within the context of this situation, and maybe a little bit of screen time is okay. And so as Dr. Antony said, just a bit of compromising is fine, but being okay with that and knowing that you're doing the best you can with the resources that you have in this at this moment, and that's okay. And so just to kind of be very compassionate towards yourself and whatever resources you have at this time.
Mm-hmm. So what I heard is you pick your battle, right? So what is the best at this situation? And maybe if we can't really solve the problem and we focus on the emotions and what can we get best, find a balance. I think that find a balance, that might be very important. Okay, so thank you so much. And let me to move on to the next question. And I did see, from the chat room, and someone, and I'm not sure whether it's still in Zoom, and someone does suffer from a PTSD, and you know, have self-harming thoughts or like actions, and might not be related to COVID-19 specifically, and but the COVID-19 definitely make it worse. And Candice, and do you have any advice or comments to just to see how to cope and how long this might take? And you know, I know you have a lot of your information from the talk, and for this case, I'm not sure whether you have some thoughts about this.
Yeah, so I mean, one thing I just want to say, if anyone's thinking about hurting themselves, by all means seek help in terms of, because someone had mentioned that they might have had suicidal thoughts. So just to make sure to send that message first and foremost. I think the second message is, you know, PTSD relative to a lot of conditions is very treatable. So I feel like I want to send a message of hope, and there are resources in the Toronto community and beyond for accessing evidence-based care. Dr. Antony, for example, is part of Ontario in rolling out these evidence-based treatments. My lab has studies that we take people and give them free treatment if they're willing to participate in assessments. So just to say, I think it's a hopeful picture for those who might be despairing. That feels important for me to say. And there was one other thing I wanted to say about, someone also mentioned that their son was struggling to try to get out. And again, like Dr. Antony said, it's a little hard for us to comment in a way we would want to comment knowing the specifics of the case, but generally the principle of what we would call graded exposures, so little steps at a time, to then put those steps together to create bigger successes, and, you know, rewarding those successive steps to try to approach would be the principle to think about in that case.
Mm-hmm.
And again, those are broad principles, not knowing the specifics, but hopefully could be of some help to people.
Yeah, I might just add, there's a number, if people are looking for recommended books other than the ones we recommended tonight, so if you want a book on trauma specifically, for example, or if you're looking for therapists, there's a number of different places where you can get that information. On my website, for example, again, it's martinantony.com. I do have a list of therapists from a lot of them in Toronto, but I have people right across Canada, across North America, and some international outside of North America as well, who do this kind of work. I also have a recommended reading list that people can download as a PDF, which has a whole section on PTSD and a section on OCD and a section on depression and so on. And it includes a mix of self-help books as well as books for professionals. So you would want to just go for the section that's relevant to you. There's a section on books for parents as well, if you've got kids who are struggling with these problems. So that's one source. But there's also organizations like Anxiety Canada, for example, the ADAA, the Anxiety and Depression Association of America, adaa.org, that provide information about possible referrals as well. And Candice may know of some good sources for trauma referrals specifically in addition.
And Marty, I just put in the chat ISTSS with regard to PTSD.org and ADAA.org. Also ABCT would be another one, right?
Yeah.
Mm-hmm. Excellent. So for those of you who do need to seek for help, and maybe like you can search up Marty's website, and there are a lot of the resources there, and you can find resources, or you can follow up with our speakers, and if they are waiting, and you can seek for help. Okay, and I have a next question is for Alex. It's I have a very active mind, and it's very difficult for me to practice mindfulness because I always drift away. I felt very frustrated, so I gave up. Any advice from Dr. Alex? So I do want to pick it up. So that question is like my question. No, literally. So I have the same problems, and seems like it's difficult for me to concentrate and to pay attention to my breathing without thinking about all the things going around in my life. So Alex, do you have any comments for those active mind people?
Yeah, so it was a little choppy for me, and I'm not sure if everyone else is having some choppy experience with the call right now, but I think that this is from Lee, is that correct?
Yeah.
Yes. So this is the thing, is that this is a very common experience with the practice, and we all have a wandering mind. That's why we often refer to our mind as being like a squirrel mind, right? Because we can't pay attention for one thing for too long. And a lot of this it's kind of encouraged in our society. You know, we don't want to pay too much attention for one thing for too long. That's why we have, you know, Twitter now. So one thing is just knowing that it's normal, that your experience it's a completely normal, common experience. It's a universal experience of having this wandering mind. And knowing that every time that you're bringing it back, every time that you notice that it's gone off, let's just say, of your anchor of the breath, that you bring it back. And that in itself is the practice of mindfulness. And there are a lot of misconceptions about the practice and what we're doing in the practice. And so again, people think that, oh, if I'm not able to focus my attention for 10 minutes straight, that I've failed at the practice. But just engaging in the practice and noticing every time that your mind wanders, that itself is the practice. And often that message is sort of missed. And so I really do encourage you. You know, I recently spoke with someone who said, you know, I did it a year ago and I just couldn't do it. And she's joined me in a weekly session. And so I really do encourage you to try to pick it up and just see if perhaps you could learn a little more about the technique and what we're doing, and perhaps lose some of the misconception that's often, I think we often kind of go to automatically when we read a book or listen listen to a talk on mindfulness. We have these faulty assumptions of what we're actually doing. So I really do encourage you to try it again and actually just realize, yeah, my mind, my attention is going to drift a billion times in a 5-minute practice. And you know what? And it changes every day. It changes on if you're more overwhelmed or stressed, there might be more mind wandering, and that's okay. It's a practice. It's a skill that we practice for the entirety of our life. We never become perfect at it. So hopefully that answers the question.
Yes, I think like as you said, the meditation is not for the purpose to get better at meditation, and it's actually get a better life, right? So it's even focused on what's going on your mind. That per se is mindfulness, to my understanding. If your mind is wandering, your mind is busy, but that paying attention to your mind, and that per se, I think it's partially that's a mindfulness.
And paying attention to the judgment that comes up. I'm not good at this. This is that, again, paying attention to the judgment. And that's, again, remember, the attitude is very important. The attitude we bring to the practice is very important. And if Lee would like to, they could contact me and I could send them the Zoom link for my weekly gathering if they want to. Again, that invitation is always open to anyone. Just email me and just say that you're interested in joining the group.
Mm-hmm. Excellent. Thank you so much. I see a lot of questions about kids, right? And I think pandemic just makes the kids' life very disorganized, and it makes the parents' life harder. And parents asked about, you know, kids, they have, for example, and I just put all the questions together so that you guys can address. And one question is about kids have depression symptom, but feel angry and refuse to see the psychologist, and how to help kids to deal with it. And I have another question is about 11 years old son starts to bite his nails and skins around the nail, and try to help out, and seems like that might be the symptom of anxiety. And so maybe what can we do to help kids showing the symptoms and like depression and anxiety? And maybe Marty can take this question.
Sure. The first thing that I would say is there are some great new resources that have come out in the last little while for parents and children, specifically during the COVID-19 pandemic. So there's a great storybook, for example, that's been published for children that's been translated into dozens of languages. There's a great guide that was produced in the US for parents to help children with anxiety and depression related to COVID-19. What I can do, Leisha, is I can email, I have a nice little resource sheet that I put together for another talk that I was giving that includes a whole bunch of different resources specifically for anxiety and depression related to COVID-19, including a section for children. So I can email you that list, and if you have a way of distributing it to people who have registered, that might be the easiest way to get that information out there. Yeah, so that would probably be easier than trying to solve all of these problems on the Zoom call right now. It's providing some more detailed information. So I'll send that to you this evening, and you'll have it available to share with people if that's okay. So there was also a question about nail biting specifically. There aren't, I'm not aware of any good books on nail biting, but there is an effective treatment for it. It's called habit reversal. And it basically involves having the child or adult start to monitor the behavior and become more aware of it, start to monitor the situations where it happens, giving the individual some other strategies to use in place of nail biting to sort of break the cycle. So every time they get an urge to bite their nails, they might squeeze a ball or play with silly putty or something like that. So some sort of competing behavior. Trying to identify what the triggers are. So for some people, the person mentioned anxiety may be a trigger. If that's the case, then helping the child to learn some other strategies for managing anxiety. With nail biting, though, it's often other things other than anxiety. It may be boredom. So people may bite their nails when they have nothing else to do. It may be sort of a perfectionism where they want to get the nail perfect. So trying to address whatever emotional state is contributing to it. There may be other strategies. So there's stuff you can paint on your nails that tastes terrible that can be help people to monitor the behavior so they're more aware of it, because a lot of times people do it, they're not even aware they're doing it. So those are a few suggestions. I'm not aware of any good books on nail biting, but there are some really good books on stopping hair pulling. And the strategies are very similar for hair pulling as they are for nail biting. So if somebody's creative, they might be able to read one of these good books on hair pulling and sort of adapt them for nail biting. That's often what I've recommended to people. So things like skin picking and nail biting and hair pulling all seem to respond fairly well to this specific group of strategies. So. Oh, I think you might be on mute, Leisha.
Okay, thank you, Marty. And I'm mindful of time, and I know our speakers already go over like 30 minutes, and we want to let them go. And if anyone have any follow-up questions or want to have resources and want to reach out and seek for support, and I see Alex posted the email, and you can search their name and their website will appear, and you can find those professors from website and follow up with them. Okay, and before we end, and I want to share my screen because I see from the chat room someone's still interested in, for all the speakers and audience, if you don't have any further questions, feel free to go. I know you have your personal life to take care of, and thank you so much. I can't say how much I thank you, Candice, Marty, and Alex, for doing this, and it's very needed and very important information for us. So I want to share the books with the audience because someone asked about the books. So here are the books. So you can feel free to take a picture and find them from a website, and hopefully I'm pretty sure they will be helpful. Okay, and I also have something to share with you. It's about people ask about the video, and video will be posted on YouTube. And if you search WeSupport, and which is a Chinese community mutual mental health support WeChat group, and you probably will find the video. And it takes a day or two, and depending how fast we process the video. And I want to show you the next slide. And here is the WeChat group. And if you speak Mandarin, Cantonese, and you speak Chinese, and this is a WeSupport on the left side, which is a 心理健康互助群. That is the WeSupport group. And if you want to join the WeChat and receive the link of the video clip and receive more information about more workshops, and I see a lot of parents ask about parenting, and we will have more parenting workshops coming up on August the 2nd and August the 7th. So stay tuned. And all the information will be posted on that WeChat group. And on the right side, and that is the online survey on COVID-19, and it's either in English or in Mandarin or Cantonese. And if you are interested, and you are welcome to scan the code and to take the survey. And I really appreciate your contribution to the research and to us to have a better understanding about COVID-19 and how to cope with it. So thank you very much for everyone for being with us, and a special thanks to all the 3 speakers, and which is a great pleasure to have you here today with our Chinese community and other guests from other communities.